welcome to the deep dive. Today, we're tackling a really significant area for your learning, esophageal cancer. You shared some detailed revision notes with us, and our mission is to transform that information into, well, a clear, high-yield discussion packed with memory tips for you.
Yeah, exactly.
Think of this as your shortcut to understanding and remembering the essentials.
Exactly. We'll be systematically going through these notes, making sure we cover all the crucial aspects of esophageal cancer, from its definition right through to prognosis and potential complications.
There you go.
Our focus is really on extracting that core knowledge and making it stick.
Okay, let's unpack this then.
Yeah.
What exactly is esophageal cancer?
Simply put, it's the development of malignant cell growth in the esophagus, that muscular tube that carries food from your throat down to your stomach.
Right.
Think of it like a faulty pipe, sort of, with rogue cells just multiplying where they shouldn't.
And the notes mentioned there are a couple of main players here, right? Two key types we need to remember.
Yes, two primary types. The first is squamous cell carcinoma, or SCC.
SCC.
Yeah. Think S for squamous and maybe S for surfaces. It comes from the surface lining cells. Historically, this was the more common one.
Okay.
And it typically occurs in the upper 2/3 of the esophagus.
Okay, upper 2/3 squamous, surface. Got it. And the other one?
The other is adenocarcinoma, or AC.
AC.
Think A for adenocarcinoma and A for acid. This one's often linked to acid reflux. Its incidence has been, rising rapidly, actually. It's now the most prevalent type in many Western countries.
Really? Okay.
And it's usually found lower down in the lower third, near where the esophagus joins the stomach, the gastroesophageal junction.
Ah, okay. And there's the definite connection with adenocarcinoma to other conditions, isn't there? Something we hear a lot about.
Precisely, yeah. Adenocarcinoma is strongly linked to gastroesophageal reflux disease, GORD, and also a condition called Barrett's esophagus, which is basically a change in the lining of the esophagus because of chronic acid exposure.
Right. That Barrett's change.
Yeah. So yeah, remember, acid can lead to adenocarcinoma, often via Barrett's. It's a key pathway.
Okay, so that's the what. Now let's move on to the why. What causes this, the etiology?
Well, the notes rightly point out that the exact cause, the specific trigger, often remains unknown.
Right.
But we do know a number of factors that significantly increase a person's risk. These are the etiological factors, or, risk factors.
Okay, so what are some of the general risk factors, the sort of big hitters?
Well, the big ones are tobacco and alcohol use, both strongly implicated.
Yeah.
They damage the esophageal lining over time.
Okay, smoking and drinking.
Then there's chronic gastroesophageal reflux disease, GERD, that persistent acid irritation we just mentioned.
Right.
Obesity is another significant factor, definitely increases susceptibility.
Right.
Also, a diet that's consistently low in fruits and vegetables is considered a risk. And long-term exposure to certain chemicals, although the notes don't specify exactly which ones here.
Makes sense. Lifestyle and chronic irritation seem key. And then there's some more specific risk factors mentioned too, aren't there? Things that really flag a higher risk.
Yes, these are really important. Barrett's esophagus, as we said, is a well-established precursor to adenocarcinoma.
Right. Barrett's AC risk.
Definitely. Think of Barrett's as a major warning sign for AC. Then chronic inflammation and also stasis in the esophagus. That's like a slowing or stagnation of food passage that can irritate the lining over time, too. This is linked more to an increased risk of SCC.
Chronic inflammation and stasis.
Yeah.
Okay, that's one to remember for SCC. What else increases SCC risk specifically?
There are also some rare conditions like ptilosis and Plummer-Vinson syndrome. Both of those increase SCC risk.
Ptilosis and Plummer-Vinson.
Yeah, maybe remember TP for ptilosis and Plummer-Vinson linked to SCC. Could help.
Good tip. TP for SCC.
Interestingly, Helicobacter pylori infection and certain environmental factors are listed as possible contributors to adenocarcinoma, though the link isn't quite as direct as with Barrett's.
H. pylori linked to AC. That's not one I'd immediately connect. What about that Japanese study on tooth loss? That seemed quite specific in the notes.
Yeah, it did. The notes mention a link found in a Japanese study between tooth loss and esophageal cancer. The exact mechanism isn't fully clear, but it's an interesting association.
Huh.
Maybe poor oral health contributes to chronic inflammation, perhaps. It's a possibility.
Definitely a surprising one. Anything else on the risk factor list?
Yes. A family history of hiatal hernia is noted as a risk factor specifically for esophageal adenocarcinoma.
Okay.
And finally, there's a general point about genetic predisposition. Some people might just be more prone to developing gastroesophageal cancers because of their genes. So family history can sometimes be a clue.
Okay, so quite a mix of potential contributors.
Mhm.
Now, how does this actually develop at a cellular level? The pathophysiology, what's going wrong inside the cells?
Exactly. So esophageal cancer arises from alterations in the cells lining the esophagus. For squamous cell carcinoma, SCC, those changes are strongly linked to the damage from smoking and alcohol over time. That damage causes the lining cells to become abnormal.
Okay, damage leads to abnormal cells for SCC. And for adenocarcinoma, the one that's increasing.
With adenocarcinoma, the key driver is that chronic acid reflux, which can lead to Barrett's esophagus.
Right.
In Barrett's, the normal squamous lining gets replaced by glandular cells. They're actually more resistant to acid.
Okay.
But the problem is these replacement cells have an increased risk of undergoing further genetic changes and becoming cancerous. So it's like one cell type gets swapped for another, and that one then goes rogue.
So both start with damage to the lining, but the initial insults are often different. But what are the shared characteristics once the cancer actually starts? What makes it cancer?
Well, regardless of the type, once cancer develops, it's characterized by uncontrolled cell growth. These cells multiply without the usual checks and balances. And crucially, both SCC and AC have the potential for metastasis. That means the cancer cells can spread to other parts of the body. That's really what makes it so dangerous.
Right, the spread. Now, if someone comes in with symptoms that could be esophageal cancer, what else might be going on? What's the differential diagnosis? What else could look like this?
Good question. This is where we need to think about other conditions that can mimic the symptoms. One common one is an esophageal stricture. That's a narrowing of the esophagus.
Okay.
But it can have various causes, like scarring from reflux or inflammation, not necessarily cancer itself.
So narrowing, but benign, potentially. What else could cause those swallowing problems?
Well, external compression of the esophagus can do it. That could be from enlarged lymph nodes in the chest, or even something like bronchial carcinoma lung cancer pressing on the esophagus from the outside.
Wow.
And then there's achalasia. That's a disorder affecting the muscles of the esophagus, how it moves food down, so it presents with swallowing difficulty too.
Okay. Motility issue.
Think of achalasia as more of a functional or motility problem initially, not a structural blockage like a tumor.
Okay, so stricture, external pressure, motility issues.
Yeah.
What about other growths or problems in the upper GI tract itself?
Right. Gastric cancer, stomach cancer can sometimes involve the lower esophagus and cause similar symptoms.
Nice.
Then you can have intramural benign tumors, like a leiomyoma. These are non-cancerous growths within the wall of the esophagus itself.
Benign tumors, too.
Also, we need to consider metastatic tumors, so cancer that has spread to the esophagus from somewhere else. Breast cancer is mentioned as a common example.
Right.
And finally, even just severe GORD itself can sometimes cause symptoms that might make you worry about something more serious. So yeah, quite a wide range of possibilities.
Definitely quite a few things to rule out. Now let's talk about who gets esophageal cancer and where. The epidemiology. Who are we most likely to see this in?
Okay, so in the UK, the notes state it's the 13th most common cancer overall. But importantly, it's a significant cause of cancer-related deaths, which really highlights how serious it can be.
Yeah.
We see a higher incidence and mortality rate in males compared to females. Maybe remember M for males having a higher risk.
Good point. M for males.
Uh-huh.
And the types, SCC and AC, are they evenly distributed in the UK?
In the UK, both SCC and adenocarcinoma are common. Globally, though, SCC is still the major diagnosis overall.
Okay.
But interestingly, in Western populations like the UK, US, Australia, we've seen this really clear increase in adenocarcinoma and Barrett's esophagus. That shift is quite important.
The trend towards AC in the West definitely seems key. What about specific numbers in the UK, just to give us a sense of scale?
The notes mention approximately 9,200 new cases diagnosed annually in the UK.
Okay.
The incidence is higher in men, even in younger age groups, surprisingly, like 25, 29. But the highest incidence is definitely in older individuals, particularly those aged 85, 89. So age is a major factor.
Age is a big one, then. What about geographical variations beyond just West versus the rest? Are there any known hotspots?
Absolutely. There are regions with very high rates, like parts of China and Iran.
Oh, right.
This has been linked to dietary factors, specifically the consumption of nitrosamine-preserved foods.
Nitrosamines.
Yeah. Maybe think CI for China and Iran and NP for nitrosamine-preserved, just to link those in your mind.
CI, NP. Got it. Nitrosamine-preserved foods. Another specific link. And what about demographic patterns within populations? Are certain ethnicities more affected by one type over the other?
Yes, there seems to be a pattern. Adenocarcinoma tends to be more prevalent in Caucasian populations,
Okay.
whereas squamous cell carcinoma is more commonly diagnosed in people of African descent. So there are definite demographic and geographical patterns that might even give you a hint towards the type.
Okay, this gives us a good picture of who's more at risk. Now, the crucial bit, what are the clues? The clinical features, signs and symptoms that might make someone suspect esophageal cancer. What are the red flags?
Right. Well, the most common symptom, and often the earliest one people notice, is dysphagia, difficulty swallowing.
Dysphagia.
Yeah. It often starts with solid foods feeling like they're sticking, and then it can progress to liquids as the cancer grows and narrows the passage.
Okay.
Unexplained weight loss is another very common and really concerning symptom. If someone says they're having trouble swallowing and losing weight without trying, that should definitely ring alarm bells.
Difficulty swallowing and weight loss, classic red flags for many things, including this. What else should we be aware of? Any other symptoms people might present with?
Chest pain is another reported symptom. Regurgitation of food can happen too. Some patients might experience hoarseness if the tumor affects the nerves controlling the voice box.
Hoarseness.
Or a chronic cough, maybe if there's irritation or aspiration going on. And just general fatigue is also common, feeling really tired all the time for no obvious reason.
So quite a range of symptoms, some more specific than others. Are there any additional features that might suggest it's more advanced?
Yes, vomiting, especially if it's persistent. And odenophagia, that's painful swallowing, not just difficulty.
Adenophagia. Painful.
Exactly. Some patients might present with melena, those dark, tarry stools, which indicates bleeding somewhere in the upper GI tract.
Right.
Loss of appetite or anorexia is also a significant feature and often points towards a more advanced stage of the disease, unfortunately.
The notes really emphasize late presentation. Why is it that people often don't get diagnosed until the cancer is quite advanced?
Yeah, unfortunately, esophageal cancer often doesn't cause really noticeable symptoms in its very early stages. So by the time patients develop those clear red flag symptoms like significant dysphagia, vomiting, anorexia, weight loss, or signs of GI bleeding, the tumor is often quite advanced. It might be unresectable, or it might have already metastasized, spread elsewhere.
That's quite sobering.
It is. That's why recognizing any early subtle signs, if they are present, is just so important.
So when should a healthcare professional really be thinking about urgent investigation? What are the triggers for a fast-track referral, say, within 2 weeks?
Okay, the guidelines are quite clear here. Offer urgent direct access upper GI endoscopy, that's a scope test within 2 weeks, for anyone presenting with new onset dysphagia.
Any age.
Any age with new dysphagia, yes. Also, for individuals aged 55 and over who present with unexplained weight loss combined with symptoms like upper abdominal pain, reflux, or dyspepsia, indigestion, urgent endoscopy should be considered.
Okay, so age 55 plus weight loss and those upper GI symptoms. Key trigger.
Definitely.
What about non-urgent referrals? When might you still investigate, but maybe not quite as rapidly?
Well, non-urgent endoscopy should be considered for people with hematemesis, that's vomiting blood.
Right.
Also, for individuals aged 55 or older with persistent upper abdominal pain or treatment-resistant reflux or dyspepsia, especially if they have other risk factors, non-urgent endoscopy is advised.
Okay, that gives a clear framework for suspicion and referral. So once that suspicion is raised, how is esophageal cancer actually diagnosed? What investigations are involved? What's the typical pathway?
The primary diagnostic tool, the gold standard really, is an upper GI endoscopy with biopsy.
The scope.
Exactly. This lets the doctor directly look inside the esophagus, see any abnormalities, and crucially, take tissue samples, biopsies. Those biopsies confirm if cancer is present and tell us the type SCC or adenocarcinoma.
Endoscopy and biopsy, definitive diagnosis.
Sure.
What about staging? That's crucial for treatment planning, right?
There.
How do doctors figure out how far it's spread?
Absolutely. Staging is critical. For locoregional staging, that's looking at how deep the tumor is in the wall and if it's spread to nearby lymph nodes, endoscopic ultrasound, or EUS is the preferred method.
EUS for local spread.
Yes. Then, for initial overall staging, looking for spread elsewhere in the body, a CT scan of the chest, abdomen, and pelvis is essential. Think of CT for the bigger picture, looking for metastases.
Okay. And are there any other imaging techniques used for staging, maybe to get even more detail?
Yes. An FDG CT scan can be very helpful. It can pick up occult metastases spread that might not be obvious on the initial CT scan. It sort of lights up areas of high activity like cancer cells.
Beat scan, okay.
And sometimes laparoscopy keyhole surgery might be used, especially for cancers near the stomach junction, to check for tiny deposits of cancer spread within the abdominal cavity called peritoneal disease, which can be hard to see on scans.
So endoscopy, ultrasound, CT, potentially PE and laparoscopy, quite a thorough workup. What about blood tests? Do they play a role?
Initial blood tests are important, yes. Things like a full blood count, FBC, urea and electrolytes, UNE, for kidney function, liver function tests, LFTs, glucose, and maybe CRP to check for inflammation. These give an assessment of the patient's general health and fitness for treatment and can sometimes show effects of the cancer, like anemia from bleeding.
So more for general health assessment than diagnosis itself.
Primarily, yes, though sometimes LFTs might hint at liver metastases, for example. But the main diagnosis comes from that endoscopy and biopsy.
Got it. Are there any other investigations that might be considered in specific situations?
Yeah, depending on findings. A chest x-ray might show obvious lung metastases, though CT is much better.
Yeah.
A double contrast barium swallow used to be common, where you swallow barium liquid and they take x-rays, but it's less used now. Endoscopy is so available. It can still show the structure, though.
Barium swallow, okay.
More detailed CT or MRI scans of the chest and upper abdomen give better staging info. We mentioned EUS and PET for staging accuracy. If there are enlarged lymph nodes in the neck you can feel, a fine needle aspiration, FNA biopsy, might be done.
FNA of neck nodes.
And if the tumor is very high up, or the patient has hoarseness or is coughing up blood, a bronchoscopy, a scope into the airways might be needed to check if the tumor is involving the airways.
Right, makes sense. It sounds like the investigation pathway is really tailored. The notes also mention some advanced techniques being looked at for diagnosis.
Yes, these are newer things, mostly aimed at improving early detection or getting more detail. Things like chromoendoscopy, using dyes during the smoke.
Guys.
Yeah, to highlight abnormal areas. High-resolution endoscopy for better images, spectroscopy, analyzing light interaction, narrow band imaging, which enhances blood vessel patterns, and autofluorescence. These are mostly still being researched for routine use, but they show promise.
Fascinating. Future directions. And there were specific points about assessing cancers right at the gastroesophageal junction.
Yes. For those junctional tumors, if the patient is potentially suitable for radical treatment, an 18F FDG PACT is recommended to check thoroughly for spread.
Okay.
Endoscopic ultrasound EUS is valuable when it guides management, but shouldn't be used just to try and distinguish between T2 and T3 stages alone. Staging laparoscopy, as we mentioned, is considered if it's likely to change the treatment plan.
Right.
And importantly, for metastatic adenocarcinoma at the junction, HER2 testing should be offered, because if it's HER2 positive, that opens the door for targeted therapy like trastuzumab.
HER2 testing. That's key for targeted therapy.
Yeah.
And finally, on investigations, the TNM staging system. Can you give us a quick overview? It's so central to treatment decisions.
Sure. TNM is the standard. T describes the tumor depth, how far it's grown into or through the esophageal wall. It ranges from TIS, which is very superficial, just in the lining, up to T4, where it's invading adjacent structures like the aorta or airways.
Okay, T for tumor depth.
N is for nodes, regional lymph node involvement. NX means they can't be assessed, N0 means no spread to nearby nodes, and N1, N2, N3 indicate increasing degrees of nodal spread.
N for nodes.
And M is for metastasis distant spread. M0 means no distant spread found. M1 means it has spread to distant organs like the liver, lungs, or distant lymph nodes.
M for metastasis.
Exactly. Putting the T, N, and M together gives you the overall stage, which is crucial. It's like the roadmap for deciding on the best treatment approach.
Right, the all-important stage. So let's move on to management. How is esophageal cancer treated? What are the general options in the toolkit?
Well, the main curative intent options usually involve surgery, chemotherapy, and radiotherapy, often in combination. Surgery aims to remove the tumor esophagectomy.
Esophagectomy.
Yes, a common type is the Ivor-Lewis procedure, removing part of the esophagus and stomach. It's major surgery, though. A significant risk is an anastomotic leak, where the join they create between the remaining esophagus and stomach doesn't heal properly. That can be serious.
Anastomotic leak, okay.
Chemotherapy is often used either before surgery neoadjuvant chemo to shrink the tumor or after surgery adjuvant chemo to try and mop up any remaining cancer cells. Radiotherapy might also be used, sometimes combined with chemoradiotherapy.
Surgery, chemo, radiotherapy, the main pillars. How does management differ based on the stage? Let's start with very early stage, T1N, small tumor, no node spread.
Okay, for T1N0, the approach depends a bit on the exact depth, T1A versus T1B, and the type, SCC versus AC. For very superficial T1A0, sometimes endoscopic mucosal resection, EMR, can be curative, basically removing the cancerous bit via the endoscope.
Wow, just with a scope.
For some very early ones, yes. And they'd also aim to eradicate any remaining Barrett's mucosa if it's present. For slightly deeper, T1BN0 adenocarcinoma, radical surgical resection is usually considered, assuming the patient is fit enough.
Okay.
For T1BN0 squamous cell carcinoma, the options are typically radical chemoradiotherapy or surgery. That decision needs careful discussion with the patient about the pros and cons of each. A curative esophagectomy generally involves removing lymph nodes from around the area to a two-field lymph node dissection.
Okay, so early stage can sometimes mean endoscopic treatment or surgery, maybe chemoradiotherapy, depending on the specifics. What about localized adenocarcinoma that's a bit more advanced but hasn't spread distantly yet?
Right. For patients with localized adenocarcinoma who are potentially surgical candidates, they're typically offered chemotherapy or chemoradiotherapy. This is usually given before surgery, neoadjuvant, or sometimes both before and after surgery.
Neoadjuvant first.
Yes, the idea is to shrink the tumor, make surgery easier, and treat any microscopic spread early. Participation in clinical trials is also strongly encouraged here, as we're always trying to improve these multimodality treatments.
And how is squamous cell carcinoma managed when it's resectable but not metastatic? Similar approach.
For resectable, non-metastatic SCC, the main options are either radical chemoradiotherapy alone, which can be curative in some cases.
Chemoradiotherapy alone.
Yes, or chemoradiotherapy followed by surgical resection. Again, it requires a very detailed discussion with the patient about the benefits, risks, side effects, and long-term consequences of each approach.
So lots of combined treatments tailored to type and stage. What happens when the cancer is advanced and unfortunately not curable? That's where palliative care comes in, focusing on quality of life, right?
Exactly. When cure isn't possible, the focus shifts entirely to palliative care, relieving symptoms, improving comfort and quality of life. There are still many things that can be done. Radiotherapy can be very effective palliatively to shrink the tumor and help with swallowing or pain. Brachytherapy, which is internal radiation delivered right to the tumor via an endoscope, can also help open the esophagus.
Brachytherapy.
Chemotherapy might be used palliatively to slow the disease progression and sometimes improve symptoms. And there are local treatments through the endoscope, like using electrocautery, plasma, or laser ablation to burn away tumor tissue and improve swallowing. Photodynamic therapy is another option sometimes used.
Lots of ways to help with swallowing then. Are there specific drug therapies for advanced disease based on those molecular markers like HER2?
Yes. For HER2 positive esophagogastric junctional adenocarcinoma that's metastatic, trastuzumab, that targeted therapy combined with chemotherapy, is a standard approach.
Trastuzumab for HER2 positive.
Correct. And for advanced or metastatic squamous cell carcinoma that has progressed after other chemo, nivolumab, which is an immunotherapy drug, might be an option. It helps the patient's own immune system fight the cancer.
Immunotherapy too. Great. And beyond the direct cancer treatments, what other support is crucial in palliative care?
Nutritional support is absolutely vital. Many patients struggle to eat. This can involve high-calorie liquid feeds, sometimes needing enteral nutrition via feeding tubes, either nasogastric tubes or maybe a PEG tube directly into the stomach.
Feeding tubes?
Yes, and effective pain relief is paramount. Also, psychological support for the patient and their family is incredibly important throughout this journey.
It's clear management is complex, highly individualized. Now, looking ahead, what's the prognosis typically like, and what are some potential complications?
Well, the prognosis, unfortunately, remains quite challenging overall for esophageal cancer. It really depends on several factors: the patient's general health beforehand, other medical conditions, and crucially, the stage at diagnosis, particularly whether it has spread to lymph nodes or distant sites.
Stage is key.
Absolutely. The earlier the stage, generally the better the outcome.
And what are the overall survival rates, just to give us a general idea?
The notes mention an overall 5-year survival rate of around 20–25% for all stages combined in the UK.
Right.
Lymph node involvement is strongly linked to a poorer prognosis. Interestingly, the survival rates seem pretty similar for adenocarcinoma and squamous cell carcinoma when compared at similar stages.
Okay.
But Preoperative chemoradiotherapy, that treatment before surgery, has been shown to improve prognosis for some, with some studies suggesting survival rates up to around 48% at 5 years in those who respond well and have surgery.
So neoadjuvant therapy can really make a difference to those numbers.
Yeah.
What about prevention and early detection? What can be done to improve those odds more broadly?
Yeah, well, prevention really focuses on reducing those modifiable risk factors we talked about: obesity, smoking, heavy alcohol use.
Lifestyle factors.
Exactly.
Mhm.
Early detection through screening or surveillance, particularly for high-risk groups like those with known Barrett's esophagus, can definitely improve survival by catching cancers earlier when they're more treatable.
Surveillance for Barrett's.
Yes, but general population screening for everyone isn't really done. The current tools aren't perfect, it would be very expensive, and the cancer isn't common enough in the general population to make it worthwhile currently.
Okay, so risk reduction and targeted surveillance for high-risk groups. Finally, what are some of the complications associated with the cancer itself or its treatment?
Complications can come from the tumor itself, like local spread invading nearby structures or distant metastasis. Treatment brings its own risks. We mentioned anastomotic leak after surgery. Chemotherapy and radiotherapy have well-known side effects like fatigue, nausea, lowered blood counts.
Treatment side effects.
Yes, and psychological impact is huge, so support there is vital. Nutritional problems are common, needing support, and even feeding tubes can have complications. So managing the cancer often involves managing these complications too.
Okay, so to recap then, esophageal cancer is malignant growth in the food pipe. Adenocarcinoma is now more common in the West, linked to reflux and Barrett's. Squamous cell carcinoma is linked more to smoking and alcohol. Early symptoms like difficulty swallowing, dysphagia, and unexplained weight loss are really key red flags, but often presentation is late.
Unfortunately, yes.
Diagnosis is via endoscopy and biopsy. Staging uses EUS, CT, PET. Treatment depends heavily on stage and type: surgery, chemo, radiotherapy, often combined. Palliative care focuses on symptoms.
Spot on. And remember those mnemonics: S for squamous surface, A for adeno acid, maybe TPP for ptylosis, Plummer, Vinson linked to SCC, and CINP for giant iron and nitrosamine preserved foods risk.
Great summary points.
And, considering that strong link between chronic reflux and adenocarcinoma, it really raises an important question for you listening to think about. What practical steps can individuals take, and maybe what public health measures could help to mitigate the impact of chronic reflux and potentially turn the tide on this rising incidence of adenocarcinoma?
Definitely some important points to mull over there for your further learning. Well, that brings us to the end of this deep dive into esophageal cancer. We really hope this structured overview with those memory tips has been a helpful and clear resource for your revision.
And for further in-depth learning, loads more questions, and comprehensive revision materials on this and many other MSRA topics, do be sure to check out pastthemsra.com.
And there are great free resources too at freemsra.com. Thanks for joining us for this deep dive. We'll catch you next time.